to the
This
demo.
was really good. Welcome back to the second part on left ventricular dysfunction. So far, we've only talked about how we can quantify it and how we can estimate it visually, but we didn't talk about what the reasons for left ventricular dysfunction are in the first place. And that's what I want to focus on in the first part of the second part on left ventricular dysfunction. Now, of course, you can easily get lost in this topic because there's many, many different causes why the myocardium can fail. But essentially, we can settle down on three key main reasons. The first is dilated cardiomyopathy, which is a myocardial disease. The second is coronary artery disease, where a myocardial infarct causes part of the ventricle to fail, and essentially the entire ventricle maybe. And then finally, valvular heart disease, especially if patients have long-standing significant valvular heart disease, then the myocardium can eventually fail as well. Dilated cardiomyopathy can be the result of a genetic cause, something that we see more and more frequently, or at least we're now able to detect it. It can be the result of myocarditis, usually a viral infection. Toxic, just think of chemotherapy, and the result of a systemic disease. Are you ready for some cases? I want you to solve them with me together and find out not only if these patients have left ventricular dysfunction, but also why their function is poor. Here's the first case. The first thing you will realize is that the left ventricle is dilated, and that contractility is poor, and that the ventricle has a very spherical shape. But the important finding here is that left ventricular function is diffusely reduced. In other words, all segments of the myocardium have poor contractility. And this is very typical of dilated cardiomyopathy. Yeah, you can even see that this patient had an ICD lead implanted here in the right heart. So the characteristics of classic dilated cardiomyopathy are dilated left ventricle and diffusely reduced left ventricular function. What about this patient here? Well, this patient too has a dilated left ventricle, and again, left ventricular function is poor, and again, it's very diffusely reduced. Now, this ventricle might not be as spherical as the one we saw previously, but still, this is a classic case of dilated cardiomyopathy. What do we have here? Now, this ventricle is a little bit more difficult to judge. Function is reduced, but the ventricle is not really dilated. What we have here is we have a region right here at the basal septum which does not contract normally. This is what we call hyperkinesia, or actually akinesia, which points to coronary artery disease as the problem. So if you have regional wall motion abnormalities in the setting of poor left ventricular function, you have to suspect that the patient has coronary artery disease. Another example. This patient has very, very poor left ventricular function. Again, function is, I would say, diffusely reduced. But what is interesting in this patient is that you can actually see the blood flow. This is what we call spontaneous contrast. Right in here, you see little swirls of blood right in the ventricle, which usually mean that the patient has low cardiac output. You can even see it here in the left atrium as it flows right into the left ventricle here. Now, not only is this a poor prognostic sign and denotes that the patient has poor left ventricular function, but it's also a patient who is in end-stage heart failure, again, because he has dilated cardiomyopathy. What about this patient? What is his left ventricular function? Does he have cardiomyopathy at all? Well, not really. This is a normal left ventricle with normal left ventricular function. I just wanted to show you this again to keep in mind that up front we have to find out if function is reduced or not. Even normal individuals might have low ejection fractions. This is a sign that the heart is working very efficiently. And it could be very difficult to sometimes distinguish them from dilated cardiomyopathy. Here is a stress echocardiogram to exemplify this. Take a look at the echo right here on the top left upper corner, right here, and you will see that this patient has, I would say, low ejection fraction, but when you exercise the patient, left ventricular function starts to get better exponentially. You see that the ventricle starts to hypercontract, and this comes to a point where the patient is able to sometimes even increases ejection fraction, stroke volume by 4 or 5-fold. So the lesson here is watch out in normal individuals, especially in athletes. In these cases, you sometimes have to use some kind of a maneuver, stress maneuver, to determine whether or not they really have cardiomyopathy or not. But I think in this patient here, you can clearly see that there is a problem. Again, let's go through this short axis view. You've learned already that we have to look at the inward motion. If you measure the ventricle, you will also see that it is dilated and hypercontractile. In addition, the myocardium is rather thick and does not thicken the way it normally should. So again, this is a patient who has poor left ventricular function, and this left ventricular function is diffusely reduced. In other words, all segments of the myocardium are hypercontractile. Again, a beautiful example of either dilated cardiomyopathy or a patient who had long-standing hypertensive heart disease, which led to heart failure in the end. What about this ventricle? Normal or not? Certainly, we have no regional wall motion abnormalities. We have very vigorous inward motion. This, again, is a normal ventricle in a healthy individual. And here, a ventricle which is diffusely reduced, but there is a region which has less contractility somewhere in the septum here. Now, this patient had a normal coronary angiogram, so in essence, he had dilated cardiomyopathy. The lesson here, even patients with dilated cardiomyopathy can have at least some regional variations in their contractility. Just to give you a subcostal view, what is left ventricular function here? Well, right ventricular function is okay, but left ventricular function is poor. A hypocontractile, dilated left ventricle, again in a patient with cardiomyopathy. Contrast it to this ventricle here. First of all, the size of the ventricle is rather small, or at least normal size. Right ventricular function is also okay, and the contractility is okay too. So again, this patient does not have left ventricular dysfunction. The last image I'll show you, again, a subcostal view. Here the left ventricle is dilated. The right ventricle is doing fine. You can even see that there is a very large left atrium here. And left ventricular function, again, is mildly reduced. I'm sure you caught most of these pathologies and you were able to judge left ventricular function. And I hope that giving you so many examples helps you in judging it in your patient. It might not be easy in certain shades of ventricular function, but if you want to look at whether or not a patient has normal or severely left ventricular dysfunction, it's rather easy. So I hope you saw a lot of cases now that will help you to solve the following questions. Here are 4 different 4-chamber views, and you will have to find out which of these 4-chamber views is normal, where left ventricular function is normal. Take a look at the individual ventricles. I'm sure you can do that. It's very simple. Okay, I'll just give you a few more seconds. Also look at the size of the ventricle. That can also point to a pathology. Well, I'm sure you caught the ventricle which is normal. Here on the top, we have a patient who had amyloidosis with very poor left ventricular function, a patient with dilated cardiomyopathy with moderately to maybe severely reduced left ventricular function, and a very severely reduced left ventricular function, a patient who had an apical infarct. And this is a normal ventricle. Now we'll turn it around. This time you will have to tell me which of these 4 ventricles has the least ejection fraction, the lowest ejection fraction. Is it the one here on the top, this one, or this one? Okay. Okay, are you ready for the answer? Again, I'm sure that most of you caught the ventricle that you definitely don't want to have yourself, and it's this one right here at the bottom right. What do we see here? We see that actually the entire interventricular septum is hypo or akinetic actually. There is hypokinesia all the way around here, and only this part is contracting normally. Okay? Now, this ventricle does not seem to be completely normal either, but it's smaller and function seems to be better. And this is a completely normal ejection fraction, as is this one here. So the right answer is this one here, a patient who had an anterior infarct. To make you fit for all clinical situations, you have to be aware of a few pitfalls. Here's an example. This is a left ventricle which is normal in size and which also appears to have a normal contractility. Now you might say this is a normal functioning left ventricle, but if I show you these additional views, you will realize that the patient has a problem. Not in the four-chamber view, but here in the apical long axis view, you will see a wall motion abnormality here, as you will right down here. Okay? So just by looking at one view, you might not detect the problem of the ventricle. Remember, the ventricle is a three-dimensional structure. Another example, if you look at the four-chamber view here on the top, you will estimate left ventricle function to be normal. But the additional two-chamber view shows you that there's a wall motion abnormality here, and it's probably diffusely reduced function somewhere down here as well. So what you have to do is you have to use as many views as possible, especially in the setting of coronary artery disease. So watch out for regional wall motion abnormalities. Another example, another pitfall. Here we have a patient who has two problems. The first problem is that he has a rather high heart rate of 90. Now, it's always very difficult to judge ejection fraction in high heart rates. And the other problem is that the patient has a left bundle branch block. You can see that there's a wide QRS complex, which causes the septum to wiggle back and forth. So this is the synchrony. Here, for comparison, is the same ventricle. Now that we reduced his heart rate, he was cardioverted, and we put on the CRT system, which is a pacemaker that causes, or which kind of relieves the left bundle branch dysynchrony problem. Compare the ventricle here with the ventricle here. Now, this ventricle function definitely looks worse than function here. So the key message here is watch out for high heart rates. It's very difficult to judge ejection fraction, and you always underestimate ejection fraction in the setting of left bundle branch block. So dysynchrony is something to watch out for. You've already seen the next pitfall, and that is poor image quality. And you'll encounter that relatively frequently. How do you judge ejection fraction in such a patient? Well, if you use a number of different views, you can still manage. And for example, in these two patients who both have poor image quality, you will be able to detect that this patient probably has a lot better ejection fraction here than this patient here on the right. And if you really want to go to a top level of looking at ejection fraction, why don't you use contrast? I showed you this example previously. Very difficult to judge here, but everything is very clear here. But this is going to be the topic of our masterclass, and there you will learn much more on new technologies and techniques that can be helpful in even very, very difficult settings. So even eyeballing of the left ventricle is not always easy. Therefore, I have two additional methods for you. The first one is called MAPSE, which stands for mitral annular plane systolic excursion. When you're looking at the mitral annular plane systolic excursion, what you're actually doing is you're trying to see how the plane of the mitral valve moves towards the apex. In essence, you can semi-quantitatively also look at that on the 2D image, but there's a way where you can quantify it directly, and that is by using M-mode. So you place the M-mode here at the medial part of the mitral annulus, right at the base of the mitral leaflet, and then you simply freeze the image. What you get here, you get the excursion of this annulus between diastole and systole, and then you simply measure the distance from the base to the tip right here. We get a value of around 14, which is completely normal. Okay, and now to the second method that I promised you. One can even use Doppler to indirectly assess left ventricle function. To do that, you can use continuous or post-wave Doppler. I'll show you with continuous wave Doppler. And replace the continuous wave Doppler across the mitral valve and acquire a good signal of mitral valve inflow.
Now, how do we interpret this curve? Well, we have the E wave here and the A wave here. The E wave is early diastolic filling, while the A wave is caused by atrial contraction. Usually, we have an E wave which is higher than the A wave, at least in normal individuals. But in patients who have poor left ventricular function, this difference can be very, very large. In other words, we could have a very, very high E wave and a relatively small or almost non-existent A wave. This denotes poor left ventricular function, as a matter of fact, elevated filling pressures. And if we also look at the steepness of the curve, in other words, the so-called deceleration time, that gives us additional information. In this case, we would have 323, which is a very, very long deceleration time, so the slope is very shallow. In patients who have poor left ventricular function, this curve would look something like this, and the deceleration time would sometimes be below 100 milliseconds. So these two parameters can be used to indirectly assess left ventricular function. However, only use them in conjunction with the other parameters we showed you previously.
In summary, some examples. Here, first of the MAPSET, the mitral annular plane systolic excursion. A patient with a normal value, you see nice excursion of the annulus versus little excursion here in a patient with cardiomyopathy. An example of Doppler, a very high E wave, a steep deceleration time in a patient with dilated cardiomyopathy versus a patient who has a relatively low E wave relative to the A wave and a not so steep curve of the deceleration in a patient who does not have left ventricular dysfunction. So you see there are a lot of techniques available to look at ejection fraction function. There are even more, especially if you go through textbooks, you will find a few technologies that I want to just briefly touch so that you at least know them. We will, however, discuss them in more detail than in the masterclass. But let's go through them very briefly and very quickly. The first one is an M-mode method, which is called fractional shortening. You perform an M-mode to the left ventricle, and basically all you do is you look at the difference in the diameter between systole and diastole and calculate a parameter which we call fractional shortening. Tissue Doppler, something which is rarely used, but which is still something that can be used for specific situations. What do you do here? You track the motion of the myocardium, and you can draw little curves that represent the motion of the myocardium in specific regions, and thereby you can calculate all sorts of parameters which allow you to look at deformation of the myocardium. Finally, three-dimensional imaging. For that, you need special three-dimensional transducers that allow you to generate the three-dimensional volume, and that you trace then, or you generate so-called pumping volumes. And these volumes give you very exact values that are probably superior to two-dimensional imaging when it comes to calculating ejection fractions. And then finally, speckle tracking, a rather new technology, which is a method that uses the grayscale image and thereby tracks the motion of the myocardium, or the motion of the fibers actually. So you're looking at myocardial function on a, I would say, contractility level. And thereby, what you do is you look at the way the myocardium contracts in its different components. In other words, longitudinal or radial, or if you use a short axis view, in a circumferential way. So you see there's many, many different ways that lead to Rome. Now, if you have a patient, the first step will still be the eyeballing of the ventricle. And then, depending on the time and your experience and the instrumentation you have in your system, you can use these additional components to look at left ventricular function. I'm sure you got something out of this lecture. And remember, in the following lectures, we'll always come back to ejection fraction. So I'm sure you'll get a lot of practice. And at the end of the course, you will be an expert.